تأخير الدقايق القليلة دي. Are we expecting some more to join us? Yeah, it's good that someone started the recording. Thank you for whoever did that. Can you hear me?
يا دكتور صوت حضرتك واضح جدا.
Okay, that's great. So probably I think we can start right now. Today, I'll present a presentation about the retinoblastoma. It's one of your lectures in the uveitis master course, and I'll try to simplify things and highlight the important things that you need to know, inshallah, so that things will become easier for you. Just a second, give me one moment to share my screen. Okay. So can you see my screen right now?
Yes, doctor, we can see.
Okay, that's brilliant. In just a second, it will come into a full screen mode right now. Okay, so there are a few important points that I need to highlight in the subject of the retinoblastoma. Of course, retinoblastoma cases are seen by oncology specialists and they are managed by oncology specialists. What's important for us as general ophthalmologists is to know the basics and the background and to not to miss a case with retinoblastoma. So we need to be very aware of the different presentations because this is not only a sight-threatening condition, but it may be a life-threatening condition. So it's a primary tumor developing from a neuroectodermal intraocular cells called the retinoblasts. It's the most common primary intraocular malignancy in children. So as I was saying that the retinoblastoma is the most common primary intraocular malignancy in children, and it's the second most common malignant intraocular tumor after malignant melanoma of the choroid, and the importance that it can lead to this. This is why it's important to know very well about this disease. The incidence is variable between countries. Usually it presents before, just a second. Usually present in young age before the age of 5 years, usually presents with leukocoria or strabismus. Those are the most common presentations. As you can see, it may be diagnosed simply in a simple photo taken for a baby. If you find a white red reflex coming in one eye, which reflects that there is a tumor back there. So it's important to understand a bit more about the genetics of the retinoblastoma. We need to differentiate between unilateral cases and bilateral cases. Bilateral cases, all of them has what we call the germline mutations. And we will know the difference between the germline mutation and the somatic mutation. Most of the unilateral cases have somatic mutations. Some of them may have germline mutation, but whenever you find a bilateral case, it's impossible to be due to a somatic mutation. There's no gender predilection, so it's equal in males and females, and there is no race predilection. So there is what we call the two-hit mechanism proposed by Knudsen in 1971, which indicates that there is what we call a tumor suppressor gene. So there is an initial mutation which leads to inactivation of one of those tumor suppressor genes. This may happen in one of the germline cells. Subsequently, it will be present in all the cells coming from this germline cell, or it may happen only in few somatic cells. Then there should be a second hit or a second mutation in one of the somatic cells developing in the retina, leading to suppression of this tumor suppression gene, and the suppression of the two alleles of the tumor suppressor genes are needed for the retinoblastoma to occur. Is it clear for you, or it needs a bit of more explanation? Can you hear me?
Yes.
Okay, is this part of the theory clear? So we need to have inactivation of both alleles of the tumor suppressor gene. The first hit may hit either the whole germ line, so the whole cells coming from the germline cell, or one of the somatic cells. If one of the cells who had a first hit will have a second hit of the second allele of the tumor suppressor gene, the patient will develop retinoblastoma. Okay, so there is what we call the
first hit or second hit.
Okay, so do you know that? Do you understand that? You know, there is what we call two alleles of the gene. Those two alleles, for example, in the autosomal dominant diseases, present of one of the dominant character genes in one of those two alleles will lead to appearance of the dominant phenotype. حضرتك فاهمة حتة alleles? Is it clear for you the meaning of the alleles or not? So each gene has two alleles, two sites of presentation on the two chromosomes that are present in the nucleus. So we have two copies of the tumor suppressor genes. Both of them need to be inactivated so that the retinoblastoma will happen. So we have a first hit of one of the alleles, then a second hit of the second allele, and these two hits will lead to uncontrolled division of the cells and development of retinoblastoma. So this hit may be due to a genetic disorder, may be due to irradiation, may be due to whatever cause, but the net result that it leads to inactivation or damage of the tumor suppressor gene on one of the chromosomes. Okay?
Okay.
وضحت شوية؟
Okay.
Okay. So for the heritable retinoblastoma, they have the first mutation in the germline cells, and they present in younger age because when a germline cell has a mutation and damage to one of the alleles of the tumor suppressor gene, this cell will divide and large number of cells will have this first hit. And thus it's not uncommon to have a second hit and develop retinoblastoma. And usually this happens in a younger age in comparison to the non-heritable retinoblastoma. In 90% of cases, they represent a new mutation without a family history of retinoblastoma. So there may be no family history of retinoblastoma, but the baby during the embryogenesis, he had a germline mutation, which led to inactivation of one of the alleles. And then he will, after birth, he or she will develop a second hit and development of retinoblastoma. The scientists could isolate the gene and the locus responsible for the tumor suppressor gene. It's called the chromosome 13, Q position 4.2. This is the locus of the gene which is isolated and found to be responsible for the development of retinoblastoma. Later on, they develop what we call the RB1 gene, or the retinoblastoma 1 gene, which is described as a tumor suppressor gene. In the past, we thought that the retinoblastoma developed due to an oncogene. Oncogene means that there is an abnormal gene which escalates or improve or increases the division of the cells. But later on, we understood that it's not like that. It's not a gene that promotes the division of the tumor cell, but it's rather a tumor suppressor gene that stops that division. And when this tumor suppressor gene is inactivated, the tumor will happen. Did you get the idea or not? I know it's a bit difficult. If you want me to repeat it, that's absolutely fine. This means either you understand everything or you understand absolutely nothing.
هو صعب جدا بصراحة.
ببساطة, so I'll explain it in Arabic for once and then I can repeat it in English. كنا زمان بنعتقد ان حاجه اسمها اونكوجين. اونكوجين ده يعني كاننا بندوس بنزين ان التيومر سيلز تبتدي تديفايد وتكون تيومر. مع الوقت ابتدى فهمنا يتغير، نفهم ان لا ده التيومر بيحصل بسبب inactivation of a tumor suppressor gene، يعني حاجه بتشيل الرجل من على الفرامل. فاهميني ازاي؟ احنا في فرامل التيومر سبريسور جين ده الفرامل اللي طول ما هي متداسه التيومر سيلز ما بتتقسمش ما بتنتشرش. لما بنحصل inactivation of the tumor suppressor gene احنا بنشيل الرجل من على الفرامل فالتيومر سيلز بتنطلق وتجري وتديفايد زي ما هي عايزه. الار بي 1 جين ده اكتشفنا ان هو تيومر سبريسور جين rather than an oncogene. And as a tumor suppressor gene, it's presented with 2 copies on the 213 chromosome. So that chromosome number 13 has 2 copies. Each one of them has a copy of the retinoblastoma 1 gene. For the retinoblastoma to happen, we need to have inactivation of both copies of the retinoblastoma 1 genes. Inheritable retinoblastoma, inactivation of the first copy occurs as a germline change, while inactivation of the second copy, it is considered as a second hit. And this is why it happens in younger age, because all the cells coming from the germline cells have already had the first hit. Okay?
Okay.
Okay, great. So, heritable retinoblastoma is occurs in about 40% of cases. All the cells carry one mutated copy of the retinoblastoma genes. All the cells, whether in the retina or in the pineal body, as we will see later on, they may have what we call a trilateral retinoblastoma. Those patients, because they have all the cells in all cells of the body, so that the tumor tends to be bilateral, so affecting both eyes, and multifocal. So whenever you find 1 focus, 2 focus, 3 foci, 4 foci, 5 foci, 6 foci in both eyes, you should start to think, no, this is not normal. All the cells have the potential to produce the tumor, so it's mostly a heritable retinoblastoma. And there is a risk of secondary tumors, what we call the trilateral retinoblastoma. As you will see later on, there is a tumor in the central nervous system which may happen in those patients, especially if they are treated with radiotherapy, as we used to do in the past. And there is a 40% chance that the offspring will develop retinoblastoma because it's transmitted as autosomal dominant inheritance. So the inheritance of this abnormal gene may be transmitted genetically, but it has an incomplete penetrance. Incomplete penetrance or 90% penetrance, this means that it will not express the phenotype in all the individuals who have the inheritance of that gene, but only in 90% of the people who will have the gene from their fathers and mothers, from the parents. Okay, if a child, this is a question that you may be asked, a child has a heritable retinoblastoma, the father and the mother will come to you and ask, what is the risk of having another child with retinoblastoma? If the parents are affected, it will be 40% because, as I explained, autosomal dominance means 50% transmission. But because there is a bit of incomplete penetrance, this decreases the chance to 40% rather than 50%. But if the parents are healthy, this means that the patient did not inherit the gene from the parents, and he had a mutation of one of the germline cells, which was acquired rather than inherited, and thus the risk of having retinoblastoma in another sibling is low because it's not inherited from the parents. Okay, so the question that you will need to ask if the patient has a heritable retinoblastoma like this, ask about the parents. Any of you suffered retinoblastoma while during childhood? If the answer is no, then it's 2% risk. If they had retinoblastoma, then it's 40% risk. Okay, I know it's difficult, but are you still surviving?
Trying.
Okay. معلش هو الموضوع صعب, but I'm trying to simplify it as much as you can so that when you will read it in Kasky, it will be easier for you. The other form
عند كده يعني affected هيبقى 50%, لو مش affected هيبقى كام في المية؟
2%. 2%, very low risk. تمام. The other form, it's called the non-heritable retinoblastoma or non-hereditary or somatic retinoblastoma. Usually, it's a unilateral solitary tumor, so you will have only one focus in one eye only. Okay. Usually, it's not transmissible, so the risk of transmission to the siblings is 0%. No risk of secondary non-ocular tumors because the first hit is not affecting all the cells of the body like the germline mutations. The risk of each sibling is very low, about 1%. 90% with unilateral retinoblastoma will have non-hereditary forms. So we need to differentiate between unilateral and bilateral, and between heritable and non-heritable, or hereditary and non-hereditary. Most of the unilateral have non-hereditary retinoblastoma, but some of them may have hereditary retinoblastoma, but only expressed in one eye. But all patients with bilateral retinoblastoma, they all have germline mutations or what we call the heritable retinoblastoma. Okay? So when we are classifying the retinoblastoma, we will classify it according to the extraocular spread, whether it's a local invasion, which is called the orbital invasion of the nearby tissues, or distant metastasis to the bone marrow, to the liver, to the lung, etc., or intraocular classification, which is classified. In the past, it was called the Rees-Ellsworth classification, and recently we use the international classification of intraocular retinoblastoma. Okay. The Rees-Ellsworth classification was developed in the 1950s, and at that time we used to use the irradiation as the method of choice of treating retinoblastoma, and we focused at that time whether we can salvage the globe or not with irradiation. So the Rees-Ellsworth classification focused whether we can salvage the globe or not, and it stratified the patients into groups from 1 to 5. Very favorable outcome, so the vision will be salvaged, or the globe will be salvaged rather than the vision. It's the globe salvage. So if it's a small tumor, small in size, posterior location, okay, to the very unfavorable outcome if it's a massive tumor involving more than half of the retina with vitreous seeds. For this one, you will need to do enucleation, but for that one, you can still salvage the globe and avoid doing the enucleation by doing radiotherapy. This was the way we treated retinoblastoma in the old ages. Now, as you will see, we use the chemotherapy rather than the radiotherapy because the radiotherapy is no longer the method of choice because of the risk of the secondary tumors. As I explained to you, there is the risk of CNS tumors like the pinealoblastoma or what we call the trilateral retinoblastoma. So we now use the chemotherapy, and because the intraocular retinoblastoma is likely to be cured, so our main objective is not just to salvage the globe and avoid enucleation, but we now have our aims higher, and we aim to cure the condition completely without enucleation and without external beam irradiation. This is why we needed to have a new classification, which is the international classification of retinoblastoma. So it goes from A to E. A means a small tumor restricted to one site. B is a large tumor, and the tumor is only confined to the retina. It's not invading the vitreous, and it's not invading the subretinal fluid. C and D, it's invading the adjacent spaces. E means unsalvageable globe, so it's a very extensive globe that you will need to do enucleation. But for those stages, it's still possible to treat it completely and cure the patient completely. Okay? So it goes from stage A.
الاوربت بس مش لكن الفيجن لا خلاص كده.
معلش سؤال تاني.
يعني انا بسيف بس الاوربت والجلوب لكن والبيشنت لايف، لكن مفيش فيجن.
لا في vision in the international classification of retinoblastoma. In those patients, we treat them, and hopefully if the patient is not having the tumor at the posterior pole, he will maintain a good central vision. If the tumor is peripheral, so you will treat the tumor and preserve the remaining part of the globe. And if the tumor is in the posterior pole like that one, the patient will maintain relatively good peripheral vision, but no central vision. But you can still preserve the vision. Okay? Did this answer your question, doctor?
يا دكتور انا
Okay.
بحسب ان انا خلاص يعني طالما في ريتنوبلاسوما خلاص يعني كده
لا 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 الدنيا يعني things changed. In the past, retinoblastoma means either enucleation or radiotherapy. So if you can just salvage the globe without having to enucleate it, it was a success. But now things are much better, and usually patients tend to maintain good vision if catched early. Okay. So it goes from stage A to stage E. You'll find, for example, stage E, small tumor only affecting the retina, located away from the foveola and away from the disc, so not involving the macula. And it goes more and more severe till stage E, which is non-salvageable. It's an extensive retinoblastoma leading to neovascular glaucoma or anterior tumor invading the anterior segment, or diffuse infiltrating retinoblastoma with opaque media, or atrophia bulbi, or what we call phthisis bulbi, or aseptic orbital cellulitis. So as you can see, it goes more and more severe, and each one of those stages will have certain way of treatment, as we'll see later on. I need to talk a bit about the histopathology of the retinoblastoma. It's formed of what we call the retinoblastoma cells, like this one. Usually it's a medium-sized cell with the features of malignancies, like what we call a high nuclear cytoplasmic ratio. This means that the size of the nucleus is large in relation to the size of the cytoplasm. Normal cells doesn't display that, so they have small nuclei. But because those are malignant cells, so they have large nuclear cytoplasmic ratio, they have increased apoptotic and mitotic activity, so they are dividing uncontrollably. So you'll find a lot of mitotic figures that you can see under the light microscope in those cells. Usually they stain blue in H&E. Usually they grow as sheets of cells surrounding a feeding vessel. One of the important features is calcification, and the calcification happens because when the cells outgrow the vascular supply, they undergo necrosis, and we find calcification. And this is one of the important clinical features that help us to differentiate the retinoblastoma from other conditions, like, for example, the Coats disease, for example. Sometimes it's a bit, a gray zone in between them. If you find calcification in the CT or the ultrasound or anything like this, it gives you a clue that this is a retinoblastoma. Okay. So we talked here about the individual cell of the retinoblastoma. Sometimes those cells, especially in differentiated forms, they form what we call a rosette or a floret. The rosette is a ring of cells surrounding an empty lumen. So we have an empty lumen here, and the cells are arranged as a rosette or a ring of cells called the Flexner-Ventersteiner rosette. Sometimes you have cells with eosinophilic fibrillary material at the center. So if you can see here, it's not clear like that one. There's a yellow, an eosinophilic, a pink fibrillary material at the center with the retinoblastoma cells arranged around it. When you find a rosette like that, this indicates good differentiation. This is not a very aggressive tumor. So if the eye is enucleated and the pathology tells that we can see rosettes, this means that the tumor was not aggressive. Usually in aggressive forms of the tumor, you will not find this differentiation. Okay. The floret, they have some photoreceptor differentiation, and this is why they may be called retinocytoma. So the cells, they have more organelles. They don't have very high nuclear cytoplasmic ratio like the undifferentiated cells. And again, when you find florets, this is a good sign. This means that the tumor is not very aggressive. Okay. Okay, I'm just admitting your colleague. Just a second. Just 1 second. When we do the screening for retinoblastoma, it can be done by the neonatologist or the pediatrician. One of the important screening things that they need to do for every neonate or child is to see the red reflex with a direct ophthalmoscope. Okay. Pediatric ophthalmologists need to examine patients who have positive family history of retinoblastoma or who have offspring or siblings of affected patients. So this means that there is a bit of higher risk of having a heritable retinoblastoma. Genetic counseling is important as screening for families with retinoblastoma baby who wants to have a second baby. So they may need to check with the genetic counseling people if the new baby have retinoblastoma genes or not. Okay. The presentation, what is very important to stress here, that you can never trust a child. Any patient with strabismus, they should have a fundus examination, because you may be treating the patient for a congenital esotropia or a refractive esotropia or accommodative esotropia, and you find out that you missed important time and you didn't do the fundus examination and the patient is having a retinoblastoma. Another important thing, don't trust a patient with orbital cellulitis, especially if there are no signs of acute or active inflammation. There is no fever, there is no redness, there is no pain. Always think this may be a retinoblastoma with local invasion. So the children are peculiar and different from the adults. You can never trust them. Always, always, always remember leukocoria, strabismus, and orbital cellulitis-like thing. Always think about retinoblastoma. Take it into consideration. Okay. So the clinical presentation can start from the intraocular signs, as we said before, or the diffuse infiltrating retinoblastoma. They have the picture of endophthalmitis-like or hemorrhage, vitreous hemorrhage. They may have local invasion through the choroid, sclera, or the optic nerve, or distant metastasis. So when a patient is diagnosed with retinoblastoma, the role of a pediatric oncologist is very important. Physical examination, light reflex, visual acuity, pupillary reflexes, proptosis if there is orbital invasion, anterior segment examination for a pseudohypopion or secondary glaucoma, dilated examination, A and B scans, because as I explained to you, sometimes you see a mass, you are not sure whether this is a retinoblastoma or a Coats disease or whatever. A and B scans of the ultrasound, you look for the calcification, is very important. Photographic documentation with a red cam or something like this, because this is the way you can check if the tumor is getting larger in size, smaller in size, new foci, response to treatment, etc. So the documentation with the fundus photos is mandatory in the management of those cases. Okay, another important thing to know that we have three patterns of retinoblastoma growth: endophytic, exophytic, and diffuse infiltrating. Endophytic means that it grows towards the vitreous. So usually the retina is not detached and the tumor grows towards the vitreous, and it may break through the Brooks membrane and give vitreous seeds. Exophytic means it grows in the subretinal space, so there is a tendency of retinal detachment and subretinal fluid accumulation, and the tumor cells will literally float in this subretinal fluid and may give this focal tumor-like thing. Okay. Diffuse infiltrating is the least frequent and the most aggressive. Usually it causes diffuse thickening of the retina without calcification. Usually there may be pseudohypopion or pseudovitritis. B-scan, as we said, we look for the calcification. It looks something like this, highly refractile like that. It confirms the associated retinal detachment, and it's important to document the height and the thickness of the tumor. CT is not preferred, especially in young children, because it imposes giving a dose of irradiation, which may activate the second hit in some more cells. So it's better to avoid the CT scan. What's important that it can show the calcium, but we usually go for the MRI. The advantages of the MRI. By the way, how can you differentiate if this is a CT scan or an MRI, and if this is a CT scan or an MRI? What makes us say that this is an MRI? Who can answer this question?
Bone in the CT scan is more shiny and white, I think.
Yeah, so the bones in the CT scan are seen very clearly like that. The soft tissues are not that great, but usually the bones are very, very evident in the CT scan. In the contrary, in the MRI, go ahead, please.
هي اللي بتقلي بتبقى more evident.
The soft tissues, yeah, the soft tissues are more evident, so you can see the optic nerve, you can see the muscles, you can see the lobes of the brain and the gyri and the sulci, etc. But the bone itself, it's not brilliant. So this is the skin. The bone is the dark part, is not very visible, and you can see the soft tissue. Okay. The good things about the
فرق ازاي بين الانواع بتاعت الريتينوبلاستوما؟ لازم بعد ما اشيلها يعني هعرف، ولا اللي هي لها الجروث بتاعها انها
لا this is a clinical no it's a clinical diagnosis if it's
يعني هشوفها
growing
بس
لا في الفندس examination او بالindirect ophthalmoscope. If it's growing, the retina is flat and the tumor grows towards the vitreous, not underlying the retina, like this one, it's an endophytic, so it's going towards the inside of the eye. The exophytic tends to grow in the subretinal space, so you find that the retina will be detached like that, and as if the tumor cell, it doesn't have the tendency to go to the vitreous. No, it has the tendency to grow on the under surface of the retina and float in the sea of the subretinal fluid there.
كنت جايب صور الترا ساوند فحضرتك قلت انها اللي هي السكند تايب، فانا بحسبها
no الالتراساوند بصي دي I'll say that this one is mostly an endophytic, mostly, but I need still to see it clinically, but it tends to grow to the inside of the globe rather than spreading underneath the retina.
لا ده انا بحسبها العكس.
No, in the exophytic, it tends to spread underneath the retina and you find a large retinal detachment. Here, no, it's you can say it's a mushroom-shaped growth in the inside of the vitreous. So it's an endophytic type. Okay. The advantages of the MRI, it avoids giving a dose of irradiation. It enables you to check the local invasion of the optic nerve or the extraocular muscle, and it can evaluate the what we call the trilateral retinoblastoma or the other neuroectodermal tumors or the pinealoblastoma. They are all the name of the same thing. Okay. Bone marrow testing is done by the or lumbar puncture are done by the pediatric oncologist if needed. We have to differentiate it from the leukocoria, other causes of the leukocoria. Most important is the Coats disease and the retinopathy of prematurity, cicatricial retinopathy of prematurity, or cicatricial persistent fetal vasculature. But most of the time we get confused whether it's Coats disease or retinoblastoma. Usually Coats disease have massive exudation due to a telangiectatic vessel here. So if you find a telangiectatic vessel, you think about Coats disease. If you find subretinal hard exudates, you think about Coats disease. Leukocoria is more common with retinoblastoma, while in Coats disease it's more described to be xanthocoria. So you find rather than a white red reflex, it's a reddish red reflex. What else? Fluorescein angiography is very useful in differentiating between them. So if you do fluorescein, you find this bulb-like dilatations in the telangiectatic blood vessels in Coats disease, and not in retinoblastoma. Toxocariasis, again, there is some eosinophilia, so you look for positive titers of toxocara, some eosinophilia, some hepatosplenomegaly. Those are suggestive of toxocariasis and more inflammation than the mass. Persistent fetal vasculature, usually you find what we call a Bregmeister papilla, or a persistent primary vitreous, a blood vessel extending from the head of the optic disc to the back surface of the retina and maybe causing a bit of cataract in the lens. And usually the globe is microphthalmic, it's smaller in size, and usually it's present at birth and not shortly after birth. Usually it's unilateral. So if you find those things, you think more about a persistent fetal vasculature rather than a retinoblastoma, and it's still presenting with leukocoria, but it's not due to retinoblastoma. Here there is what's called the elongated ciliary processes. So those are the ciliary processes here, if you can see them. If you look and find those ciliary processes after dilation, this goes more with the persistent fetal vasculature. What about the treatment? As we said, we used to treat those patients with irradiation. Now we treat them with chemotherapy. So we do what we call a chemo reduction. We give what we call a consolidative therapy to shrink the tumor, and then we do a focal therapy afterwards. So we send the patient to have the chemo, and then the patient comes back and we do either a cryotherapy or a TTT or whatever we do to have two advantages: directly destruct the tumor cells which were shrinked after the chemotherapy, and then break the blood ocular barrier and increase the penetration of the chemotherapy. So the patient goes to cycles of chemotherapy, and then we do focal treatment. If it's posterior location like that, we may need to do a transpupillary thermotherapy, a TTT. If it's in a peripheral location, we may do some cryotherapy on the tumor in order to decrease the size of the tumor. Okay, so for example, this is a patient who had a tumor relatively regressed after systemic chemotherapy, and then when you follow the patient up, there is a new tumor that started to appear adjacent to the old tumor, and it necessitates repeating the treatment. So the general principles of the treatment: we want to preserve the life of the child, we want to preserve the globe, and the new thing, we want to preserve the vision while minimizing the side effects and the complications of the treatment. Enucleation is the definitive treatment, but it will entail loss of the vision and loss of the globe. We do it in advanced unilateral cases. So if you have a case like that, massive tumor invading almost to the back of the lens, the globe is non-salvageable, and it's unilateral. The other eye is completely normal. So it may be wise to enucleate that eye to preserve the life of the patient and preserve the vision in the other eye. Okay.
Okay.
Okay. So the globe salvage treatment, as we said, in small tumors, we may need to do the consolidation treatment alone. We don't need to do the cryo. We do only local treatment with, we don't need to do chemotherapy. Sorry, we do consolidation treatment alone. We don't do chemo. We treat only the tumor locally, either with cryotherapy, laser photocoagulation, TTT, which is called hyperthermia or transpupillary thermotherapy, or plaque irradiation. So you put a radioactive plaque located to the site of the tumor, which will give just local irradiation to the tumor, and you solve the problem. But this is feasible only in small tumors. If the tumor is a bit larger, we give chemotherapy, systemic, followed with local consolidation, as we said, or we may go to what we call the intra-arterial chemotherapy, or we may go for an intravitreal chemotherapy for the vitreous seeds. In the past, we used to do external beam irradiation. We try to avoid it. It still has a role in recurrent tumors and in vitreous seeds, because usually the vitreous seeds are difficult to treat. We treat them either with intravitreal injection, but the intravitreal injection, the main problem that you will give a route for the tumor cells to pass to the systemic circulation. So we don't do it regularly. Although there are some, research about doing it with very thin needles and very special considerations. But in the past, we used to do the external beam irradiation for the intravitreal seeds, because the chemotherapy doesn't reach them through the blood, so they are a bit problematic in the treatment, those intravitreal seeds. Okay. So for group A, we do focal consolidation therapy alone will be enough. Group B, we do 2-agent chemotherapy, vincristine and carboplatin, followed by with local therapy. Group C and D, we do for a more aggressive chemotherapy. Group E, we go for enucleation. There is what we call a group F trial, tumors massively involving the optic nerve. We still are looking for what is the best treatment for them. But as you can see, we try to salvage the globe, except in very advanced groups in which we need to enucleate the eye. The intra-arterial chemotherapy is done by an interventional radiologist. So he or she will go with a catheter through the femoral artery and going through the carotid arteries to the ophthalmic artery and then to the central retinal artery, reaching here and injecting the chemotherapy. So it gives a better local delivery of the chemotherapy, reducing the systemic side effects. You can imagine how bad the children do with the systemic chemotherapy, starting from loss of hair, loss of weight, loss of appetite, loss of immunity. So it's not an easy journey. So if you can deliver it locally, it gives better response, but it's not easy and it's not cheap. Response rates are superior to systemic chemotherapy or systemic chemoreduction, especially as primary therapy. So if you do it, it will cause more shrinkage of the tumor because it's focused on the tumor. There are some side effects about the dosing, about the strokes, because you go in the carotid artery, and about occlusive choroidopathy. So you may have some occlusion of the sector of the choroidal vessels. And we use an agent which is called the melphalan. It's very important to know that name, which is used in the intra-arterial chemotherapy. Intravitreal chemotherapy, as I told you, the main indication is to control the vitreous seeds. The chemotherapeutic agent may cause some retinopathy, as in a form of salt and pepper retinopathy. It's an important second-line therapy for recurrent vitreous seeds. So for vitreous seeds, we start the usual treatment with the systemic chemotherapy, and only if it's recurrent, we go for the intravitreal chemotherapy. Surgical treatment. What's the difference between enucleation and evisceration and excenteration, and which one we prefer in chemotherapy? You can answer this question, please.
Inoculation?
Yeah, we do enucleation. Why? Why do we do enucleation and not evisceration in those cases?
Evisceration, I think, will cause more spread.
Exactly. So in evisceration, what happens in evisceration, that I open the cornea and I eviscerate the content of the globe while preserving the sclera. If I open the cornea, I will give access to the tumor cells that are present inside to gain access to the blood and give distant metastasis. So here I want to remove the globe on tutu. So remove it as it is with the sclera and with the cornea and with everything, while maintaining the bulb inside. I don't want to open the bulb, okay? So I need to remove it, and even we try to remove at least 1 centimeter to the of the optic nerve, because the tumor may spread through the optic nerve. So you want to make sure that you get a good chunk of the optic nerve, 1 centimeter, to decrease the risk of having remnants of the tumor. And we try to put an orbital implant to compensate for the size of the removed globe, because remember, we remove the eye in a young child, and the orbital implant will replace that side and help the growth of the face, because if you will not put this implant, there may be a facial what's called a hemifacial hypoplasia. So this half of the face may not grow like the size of the other eye. And then we go for fitting an ocular prosthesis to maintain the aesthetic appearance, okay? If it's an extraocular retinoblastoma, if it's limited to the orbit, we use chemotherapy followed by surgical debulking. Usually excenteration is done in those patients, but sometimes it's not easy to do a complete excenterization, so you go for chemotherapy to reduce the burden of the tumor, and then debulking, and you may use radiation if needed. But the main problem is with the systemic metastasis of if there is a CNS involvement. We do what we call an aggressive high dose chemotherapy, HDC. We go for multiple agents to use them in 4 cycles, and we may need to do radiation, so we need to be very, very aggressive. Usually this is done by the pediatric oncologist, but we need to know that patients with distant metastasis or CNS involvement, they usually do poor and have poor prognosis. A very quick word about the trilateral retinoblastoma. So those are patients with bilateral retinoblastoma. So they are by definition heritable or non-heritable?
Heritable.
Heritable retinoblastoma, and they have a neuroectodermal tumor, or what we call PNET, primitive neuroectodermal tumor. Usually, or all of the time, they have germline retinoblastoma or heritable retinoblastoma in all cells of the body, including the brain cells. And this is why they tend to develop the tumor at that area, and we call it trilateral retinoblastoma. So they have right retinoblastoma, left retinoblastoma, and central retinoblastoma in the CNS. Okay, they are treated very aggressively as if they have CNS metastasis. They are usually diagnosed with a brain MRI. So when you send the patient to have an MRI and you mention that he or she has a retinoblastoma, usually they do a MRI head as well to check if they have something like that or not. Okay, we don't see it frequently now in comparison to the old age in which the irradiation was the main therapy, because the irradiation itself could cause a second hit of the retinoblastoma gene, of the tumor suppressor gene. Now, because we use the chemotherapy, so we don't see it frequently. Okay, so follow-up is mandatory in those patients after successful treatment. Especially if eye salvaging, if you don't enucleate the eye, you need to follow it up thoroughly, because there may be recurrence of the tumor. Once the tumor regresses, it takes one of 2 appearances, either a calcific mass or a fish flesh appearance. So it's not very vascular and very active like the Can you see the difference between this one? This is an active tumor. If I see this one, I say this is an active tumor that requires treatment. And if you will look at that one, it's a white calcific tumor. Can you see the difference in between them? I'll say that this is not very active. This one, again, it's vascular and active, and it's not calcific like that one. So it's important to check whether it's an active or a new one, and know the appearance of the regressed tumors. Okay, for a typical schedule, examination under anesthesia is done every 1 to 2 months till the age of 3, and less frequently afterwards. For retinoblastoma, they need a long-term follow-ups because of the risk of other forms of malignancy like osteosarcoma or CNS tumors or melanoma, etc., etc. Okay, this will conclude our lecture. Do you have any questions or concerns? I know it's not an easy lecture. I hope I made it a bit simple to you. But of course, you need to read it. And of course, you will come up with questions. I'm not sure if you have my email or my contact number or not.
I have your contact number.
Okay, so if you have any questions, please don't hesitate to send me on email or on WhatsApp, and I can answer you the questions. Hopefully, it will be a bit clearer for you. Please try to study it in Kalski as soon as possible. And inshallah, it will be easy for you.
دكتور بس ممكن أسأل سؤال، ممكن سؤال مش غبي شوية، بس يعني فضول. بس هو ليه احنا بناخد الريتينوبلاستوما في كورس اليوفي مش الريتينا؟
علشان هو it's دايما في the question is why you are studying the retinoblastoma in the UVA course and not in the retina course. Usually in most of the curricula all over the world, it's called the uvea and intraocular tumor. uveitis and intraocular tumors are considered as one unit in most of the curricula of the ophthalmology all over the world. هو صوت حضرتك بيقطع شويه دكتوره، بس هو because as I told you the most common intraocular primary tumor is the choroidal melanoma. Most of the intraocular tumors come from the choroidal origin, and only the retinoblastoma is the most famous one, not coming from the choroidal origin, but it goes with the with the intraocular tumors. So they are taken together as one, and they are studied in the course of choroidal tumors and and uveitis. Okay. Any other questions? هو صوت حضرتك بيقطع خالص. لو تحبي ممكن تكتبي لي على الشات لو تحبي، لان انا مش عارف اسمع حضرتك.
هي تقريبا دكتور كانت بتسأل ان هي يعني هل الريتينوبلاستوما بتأثر على يعني اليوفيال تراكت في اي حاجة؟ ده اول سؤال كان ليها.
لا مش لا، هي it's primarily a retinal tumor rather than a choroidal tumor. It doesn't affect the choroid or the uveal tract, but as I explained to you, because most of the intraocular tumor are choroidal, so the retinoblastoma is taken with them. Okay, any other questions? Okay.
Okay.
Okay. Thanks a lot for your attention. I hope you will, have a good night, and inshallah see you later. Inshallah. Assalamu alaikum.
عليكم السلام.
نعم.
Assalamu.